limited visibility of people's faces now, so if anything pops up or hands. Oh, Ruth, hello. See your hand.
No, I was trying to find the thumbs up for you.
That's
Sorry.
Okay. No, great. Yeah, so if I do miss something or chat or question in the chat, then please someone just shout out and let me know, and I'll try and pick that up. Okay, so if you're wondering if you're in the right place, so this is the All Wales Community of Practice for Community Neurological Services. So this is the right place. Today we're going to be talking around communication and partnership, and as with all the sessions so far, there's the self-audit tool. So we've got the QR codes there, and then on the first few slides, and it'd be really good if you could just take a few minutes, just whilst we're doing the introductions and go through the agenda, just to select on those and to complete that self-audit. I think there's 5 questions in each one. It shouldn't take very long, but it helps give us an understanding of where services and service users perceive, how they perceive that best practice standard is being delivered. So if people could take the time to do that, we do really look at these, and I'll go through some of the previous results as well. So that's what we're going to be talking about today. This is our agenda for today. So we've got some introductions and stuff, which I'll go through now. We'll do a quick recap of the previous session and talk about the terms of reference that we've sent across to everyone, and then we'll get straight into the meat of the meeting, where we'll be talking about communication and partnership and how it's integrated into services. And we've got colleagues from Betsy Cadwallader and Cardiff and Vale. So a little bit of housekeeping. So the session is going to be recorded. It will be available by Freedom of Information, and as we've been doing, we'll be releasing it on a YouTube link for those who don't have access to the recording via the MS Teams link. So you'll be able to review it afterwards if you wanted to. And then just a little bit about etiquette. So before we mentioned about if you can keep your cameras on and microphones off, that would be really useful to sort of show engagement with the session. But also we got a little bit in. It was brought to our attention by one of by Ellie in the team that if people need the flexibility to move around and to maybe have a drink or to go to the toilet, and please do that. Don't feel that you have to sit to the screen. If you've got needs, then please see to your needs. And then I know it's very, very tempting with your emails in the background to try and send a few quick emails. If you can resist that temptation and give your full attention to the people speaking, to engage in a conversation, I think that really showed in the last session. It was a really fruitful conversation. So if people are willing to stick with that, then that'd be great. So I just thought I'd comment on the terms of reference from the last session. So we presented the terms of reference the last session, and then we've circulated it for review. There's been no comments come back. We've had a couple of suggestions around the co-chair and the utilisation of someone with lived experience, which I'm fully on board with, and I'll go into the detail of that and the sort of the nuances with that decision in a moment, and how we're going to sort of move forward with that. But there is another QR code here, and I wonder if Emma, if you could put this link in the chat, please. This is a vote for the terms of reference. So rather than us assuming that no comment is agreement of the terms of reference, I'd really appreciate it if people took the time to vote on whether they agree with the terms of reference or not. And if you don't agree with the terms of reference for whatever reason, please put the reason why into the MS form, so we can understand what it is that the adjustments need to be made, or why it is that you don't agree with the terms of reference in its current format. And we don't have to get it signed off by the end of today, but it'd be nice if we could really get close to the point where we're happy with it, and then we can plan a review process as well. So if people could take the time to do that, and we'll circulate the links again following the session, along with the terms of reference if we need to make sure people have got sight of that. The other section was the co-chair. So I think there was good agreement that the utilisation of someone with lived experience as a co-chair would be a really good way forward for this group, and I'm fully behind that. I think as the performance improvement unit, we haven't got clear guidance on how to go about doing that at the moment. Although on the surface it seems as straightforward as getting some nominations and putting that out for people to review, I think we've got to be very cautious in the performance improvement to make sure we're doing it very appropriately, and we're not there yet in terms of our governance and how we manage that, and what support we need to provide that person, if indeed any. So there's a consultation process that's gone out at the moment within the networks around how do we utilize co-production and people with lived experience, and how do we bring them into the work that we do. But there's some documentation in development around how we do that appropriately, and we're not there yet about how we assign a co-chair, someone with lived experience. So we're aware of it. We haven't been able to sign it off or finalize that point yet, but we are looking into it, and it is a wider piece of work that's going on in the networks, not just within this group. And there's others on the call. Like I know that Beth's been involved in some conversations, and Michelle Price as well, looking at how we utilize co-production in these forums. So I'm afraid to say we haven't got an answer just yet, but that is the honesty. So the honest feedback is that we can't move forward yet and nominate someone with lived experience or as a co-chair. So I just wanted to be upfront with that. So I would just wonder if anyone had any questions about that, about those 2 points, about the terms of reference and the co-chair.
I was just going to say, Nick, around the co-chair, I think that's completely the right thing to do, rather than just put something in place without thought would be disingenuous to everybody. So I think to make sure it's being considered in a very thoughtful way with other groups is really important.
Yeah, thank you, Stuart. That's great to hear, because that's what we want to do. We want to do it well once and avoid any confusion or issues. And I think this is all quite new to the networks. This utilization of people with lived experience and co-producing the network strategies, that's quite new to us. So we're not there. Our health boards are probably much further along that process. So we do need to catch up a little bit, but there are obviously processes in place. So we'll just have to wait and see what the consultation shows, and then we're working with Michelle in some of the work that she's doing to try and utilize that as well. Okay, so that's okay on terms of reference. I said we'll circulate that again. If you could take the time to vote, that would be great, because that'll inform us as to whether people are happy with the approach that we're taking and the agreement that we're all in. So this is looking at the self-audit results from the last session. So I know I did this in the second session, and it's a little dry to go through, and I'm not going to spend too much time on it, but I just want to draw your attention to a few points. So these questions for the service providers are around how we conduct our assessments. Are they needs-based? Are they not diagnosis-led? Are they taking in a full person's view, the culture, their environment, their family, the support? And then we asked, the self-audit asks if you agree as a clinician or a healthcare provider, mostly agree, mostly disagree, or disagree. And generally, there's strong agreement from service providers that they're providing a biopsychosocial service or service that meets those needs. We've also done it with the service users, and I just want to just quickly move to that slide, and just so you can see the difference. It's not a huge change, and the numbers are still our limiting factor, which is representative of the group, because we have lower numbers of lived experience in this group. But there is a shift. It's not as strong in agreement with the delivery of the biopsychosocial approach. And these questions are different, but they are designed to be very similar. So they do touch very closely to the questions of the service provider. So there's just a broader spread. And I suppose the point I'm trying to make with this is that we mentioned last time about encouraging service providers to go out and audit and survey their users to see that spread, to try and make sure that we're marrying services up to meet the needs of people and meeting their expectations of services. Then there is moving on to the evaluation feedback as well. So at the end of every session, we're asking for some brief evaluation feedback, which I know is probably the hardest thing to do in these forums, because it's after the session usually, and the evaluation doesn't get done. We did low responses after the second session. I just urge people to please really go back to those evaluation forms after the sessions or at the end of this session and fill in, because we are taking them very seriously in terms of what's been put on there, particularly the bit around the health board commitments. And I just wanted to share with you what we're actually doing with those and why it's important for us to look at those commitments from health boards. So I just need to change my screen, so bear with me. And I'm aware I'm doing a lot of talking. I plan to stop very soon. So in the last session, we discussed how do we utilize these health board commitments and support teams to implement them, or to have a space for them to be held so we can support the implementation. So we're taking that administration burden off you. Padlet was mentioned, as was Whiteboard. Padlet needs a license, which we we've been encouraged to explore those routes that we do already have licenses for, and whiteboard is one of them. And this is something that's available to anyone working in NHS Wales, and this is currently only available to people to see who work in NHS Wales. So it's a way of tracking and collating those responses. So what I've done is I've put the best practice standards across the top, and then down the side each health board. And I've just extracted all of the commitments that people have said they could and should do on the back of the sessions that we've had, and I've put them into the boxes to correspond with that. So last session there was discussion around we should be able to see each other's and we should be able to see what people are working on. And I've just populated this as a draft really, just to see what people's thoughts are. And I know some of it's blurred, but the function within Whiteboard means that you can scroll into a very high amount and you can then dissect what you're doing. So I've put this together. I just hope this maybe is a starting point, and it might be useful to use this as a bit of a checklist. So for example, someone in CTM has said, I'm going to start with the audit tool and review patient-centered approach and then review the audit outcome. And I just suggest if that was something that was done, you could just highlight it, click a tick, and just put a tick on it. If you'd reviewed the audit, you could put a tick on it. If there was extra work that needed to be done, you could just add a comment. Or if it was no longer appropriate, or if you needed to change it or make it or change the wording to suit your needs, then you could easily do that. So it's a very user-friendly piece of software. And I just wonder what people's thoughts are on this as a format to try and capture some of those sort of suggestions that we should do or services should do following the end of the session. So I'll just open that up to everyone and just see what people's thoughts are, if anyone's got any thoughts or suggestions on how I can make it better or to try it. Or Linda.
I just had a little go at clicking on the whiteboard link. Can you hear me?
Yes, I can. Yeah.
And yeah, so it looks great. It looks nice and easy, but it wouldn't let me connect to the link that you had on your screen. That's the only thing. But yeah,
Okay.
It looks good too.
Okay. Well, we can definitely share the links, Linda. We can take that to the next session, see if you've had a chance to get onto it and have a play around. It's nothing I've used before, so I'm if people have got experience, then please just let me know or let us know, and we can try and tweak it. But we're just trying to capture what's being said and try and support that implementation and to tweak behaviours if we need to allow us to deliver on those standards. Beth, I can see you've got your hand up.
Hi, Nick. Just wanted to raise a question that's been added into the chat from Janet Patterson. It says, what about people working for the third sector?
Yeah, good point. I don't know if we've captured any. I don't think we've had any feedback from third sector. I can go back and check that though, Janet. Good point. I don't know if anyone's got suggestions about that. I don't know if I have the answer right now, but it's something we can definitely consider. Janet, have you got an idea or suggestion? I think, Janet, you suggested you were moving between locations. I'm not sure you can be, but if I don't know if you can come in on the conversation there. And
hi Nick, yeah, it's I'm on the train on the way to the Bolton Centre. I am. Yeah, it's quite difficult. I think this issue was raised quite a few times, and I think there's quite a few third sectors in the call as well.
Absolutely.
You know, if you don't have access to an NHS email account, we're very limited to how much we can communicate really, and that's a huge barrier. And I think Rob, we have raised it with Rob as well. I think he's looking into ways how we can communicate better too.
Okay, thank you.
Cheers, thank you.
Okay, Reese.
Yeah, I just wanted to comment on what Michelle said. I think because it's only open to people with an NHS email address, because I've got a full team suite through the organisation I'm involved with, and I can't access your whiteboard.
Okay. Okay. So a bit of work for us to do there to work out how we can support the third sector to have access to something similar. And then make sure the links are functioning and get those across. Okay. But if anyone's got any suggestions in the meantime about how we could do that, and I know Padlet might be a way forward, but we've been encouraged to try and use our existing software licenses. So if people have got
I think what you need to do is, I don't know if you can do it from your end, but you need to go, because we do this when we have guests on our meetings as well. You need to add them into a Teams group to add so they can access the whiteboard. and
Okay.
make a Teams group maybe specifically for this meeting and add all those external email addresses to that, and then they can access the whiteboard.
Thanks, Reece. Like I said, this is all very new to us here. Was working with you guys to
Probably
try
have
and make
to,
sure.
assuming through all the declarations and everything, you probably have to come from someone higher up to add external email addresses to a Teams group.
Okay, well, I've written that as a note now, so we can definitely explore that. I'm sure the team are taking that, so thank you. Okay, so a possible solution there. We'll keep working with this. I'll share the links, make sure that initially for NHS emails, make sure it's usable, and we'll try and use that, and then we'll go from there. Okay, fab. I'm just going to quickly go back to the presentation. So the other thing on the presentation, on the review, was last session we looked at, we attempted a breakout room, which wasn't hugely successful, but we did manage to get some really good conversation around what needs to be in a service to deliver on a biopsychosocial approach. So I hope people can see my screen now. So what we've tried to do is we all capture, so all of us working in performance improvement, we tried to capture all the responses to the questions that we posed the group. And the reason I'm showing you this is that I want you to realize that we are taking this very seriously, and we're working really hard to try and capture the thoughts of the group. So we've gone through and we've tried to put some themes to what was said. So on the top left, we've got the questions that we asked, next to a theme, then the current barriers, then next to that is the theme, then next to that is what were the levers, and then the theme. So these are the things we discussed in the last session, and we've tried to take what was fed back, and then we've tried to theme it to try and see what the commonalities are. So we've gone through all of the responses, and then myself and the team have then gone through all the comments in the chat, and we've pulled those out and we've tried to theme those. And I've made a little summary here, which I hope that you can see, and I'll just read through for those who can't. So this was looking at biopsychosocial approach and what we need in place in services. And if we were designing a service, what do we need to allow us to provide that? So in summary, the comments related to services being provided in suitable locations and where possible with other services, so health, social, community, third sector. Ensuring that there were links between the services and the community were key, and utilising existing resources and then enhancing the offer was a strong theme that came out in the discussion. The ability for individuals to work adaptively to ensure that they were focused on what was most important to a person was central to the discussion. And we had a lot of discussion after Linda's presentation around how do we do that? What are the issues? Education to staff to provide psychologically informed assessment and interventions was also mentioned. And there was also some comments around undergraduate influence to try and influence the way that assessments are undertaken. And then there were comments for a strong strategic direction and standardization, which would link to service specifications and links to previous comments around measuring value and data standards. And in terms of the restrictions, the main ones were listed and sort of highlighted as financial and transport. And then the levers it was suggested that leadership, professional bodies and co-production were key to support change. I wonder if people can just give me their thoughts on whether they think that is a fair representation of the session that we've had. I know it's a couple of weeks ago now. We have been through and themed as best we can, but I'd be happy to take suggestions or comments on what they feel, if they feel that represents the session. Some thumbs up. Okay. So some of you might be thinking, well, why do we do that? Why have we done that? And what's the purpose? So what I've tried to do is, because the questions are around how do you design services to deliver that, I've then looked at what the elements of a service specification would need to be. So for those who aren't familiar with the service specification, that is a document that essentially describes what a service should provide and why. So the what and the why. So what elements need to be in place to provide a service, so that there's a place to go back to as the values of that service, the reasons why they operate and what they do. It doesn't tell the service how to do it, or the health board how to do it. And that's really key, because it allows health boards to be able to deliver on how they can, on their local priorities and their resources. So what I've tried to do is take what we've discussed in that session and the summary of that and attach it to a service specification to see if we can, if it would fit. So as you can see, I've put some headings down the side on the left. and I've tried to put the comments into it. I've then linked it back to policies and documents and guidance. So the primary care model for Wales, some nice standards, the AHP framework, the quality statement for neurological conditions, and then linked it right back to the standards that we're discussing in the sessions. And if I'm honest, it all links to most of the standards, but I've just tried to pick the key ones. So just start to formulate a bit of a service specification to try and understand what's required in a service supporting people with neurological conditions. Now, in terms of why we're doing that, so moving down the line a little bit further, I'll just put this slide back up. So the reason that I'm trying to collate that, because there's a huge emphasis on reducing health inequalities and unwarranted variation, and there's definitely a need to shift from condition-specific to needs-based rehabilitation across Wales and the UK, and that's in response to the rising demands of the population with the comorbidities and the complexities that we're presenting with. And there's already many services on the call who are already doing that. They're already providing needs-based therapies, but I'm aware there's not a standard between us. We're all talking about the same things, but whether there's one place that's documented and we're all working towards as a benchmark. So there's already, as I said, there's already some good examples of that. But it's the unwarranted variation that we as health providers are tasked with reducing, and that is the whole purpose of the performance improvement unit, and is embedded within the quality statements that we have within neurological conditions, but all of the quality statements. So one way of doing that is through developing service specifications, so the why and the what of services and what should they be delivering, so that we can work towards a minimum standard or minimum offer. So that's where there may be a need for us in this forum to describe and document what needs to be in place in a service specification for neurological conditions. And that can act as a benchmark for those services, some services to work towards. It might be to describe what some services are already doing, but to try and spread that good practice. But it's ultimately to ensure that people across Wales have access to the same opportunity of outcome through services providing a similar standard of care, and there's no unwarranted or reducing the unwarranted variation between services. So what I'm proposing at this point is that we just continue with to build on the thematic approach that we've taken within the network, and we just try and capture your thoughts throughout the sessions about what needs to be included in services, what seems to come out as strong themes, and then towards the end of the community practice, reflect that back to yourselves as a group, and just to see if we can shape that, and if there's a need for us to shape it in a way that maybe sits really nicely with a service specification. I'm hesitant to pounce it upon the group and say, well, this is what we're doing, because there's already really, really good services and good practice of needs-based rehabilitation happening. And I think we need to come on that journey together to shape services in Wales. And if we can get that consensus through the group, I think that would be an easier place to work towards. And I just thought I'd leave it there and put it to the group what their thoughts are on that. Now, I do need to just highlight before I do that Michelle Price is on the call, and she is also working on this broad needs-based offer within the networks and how we take that forward as performance improvement. And we are linking together. So I'm trying to reassure people that there's not going to be duplication here. We're trying to work in tandem, but recognizing that we might be at different stages and different groups. So I think the building of that thematic approach is probably, for me, it feels like a good place to start, but I just open it up and see what people's thoughts are. Do people agree with it as a principle that we will just try and capture the thoughts of the group going forward and then see how we shape it towards the end of the sessions? We've got 2 sessions at the end of the community practice with no standard attached, and that might be an opportunity for us to discuss some of this and whether we take that forward. I've got a thumbs up there. Okay. Something's popped up. Yes, I think that makes sense. Okay, great. Thank you. I've got a question, Jenny.
Sorry, again, I was meaning to thumbs up and I've put the question hands up.
That's okay. It's nice to hear someone else talk other than just me. So thank you. I'm a bit anxious about this, about just throwing service specifications on people, because I don't want them to think, well, it's a criticism of services. It's really not. It's just a way of trying to support services who have got really good services to spread that good practice. And for those who are working towards something, but maybe are coming against barriers in health board or in other areas, it might be a lever for us to support. Because if we can produce this national consensus document that all services in Wales are working towards this, then that gives us some leverage at health board level to say, well, we're all doing this for very good reason. It's built-in evidence, it's national consensus to reduce unwarranted variation, to support your demographic. Then it just gives us a building block for a persuasive argument. Ruth.
So you've got a bit of feedback. I just think the idea of really building up the comment and trying to generate that joint and partnership working around the different issues that you're raising is really positive, because I've worked with a few service specifications specifically around mental health and neurological conditions over in England, and you still have to work very, very hard to enable people to understand what that actually means in practice. So I would support you in the idea that having these conversations and then generating that understanding is a really, really important part of actually delivering the change in services. Thanks.
Thank you, Ruth. That's really helpful. Thank you. And so myself and the team will try and take the commonalities out of each of the session and the main themes, and we'll try and make sure we're representing those. And I'll think about how we categorize those. Maybe we need to carry on that table I've put together, but just as a starting point, I thought we'd carry on with that. Okay, to save me from talking anymore, I think we're just going to go on to communication and partnership. So this is going back to the standard and what it is. So there's two definitions in the document, the best practice standards. There's the practitioner, and it talks about rehab being organised in ways to ensure good communication between the person, their family carers, and the network and all agencies involved. And then from a person's perspective, it's everyone involved in my rehab is clear on what is happening, when and why, includes me and any of my support network. So we're going to be handing over now to some colleagues from BCU. So Lee Campbell, who's a clinical specialist neurophysio working in the brain injury services in Betsy Cadwallader. I think Lee's going to start us off. Stuart, I'll come to you as well. And then after Lee, we're going to go to Esther Goodhue, who's a senior specialist speech and language therapist at Carlton Vale Live Well Services. Stuart, did you want to come in before that?
Yeah, I think so. It was just based on the two standards that that you put up previously here. Yep. The person one. For me, there's something. Everybody involved in my area is clear on what's happening, what and why. This includes me and my support network. I personally would want to see a comment in there or a word in there which is about me being at the center of the process.
Okay.
I don't know what you think about that.
Yeah, no, I kind of agree with what you're saying, Stuart. I think it all needs to be revolved around the person that's receiving the care, and I think that's the main thing. I think, and obviously the people that providing the care are going to want to give the best care in the way possible. So I think you have to focus on the needs of that specific individual. And I find that's one of the biggest problems at the moment is everyone's just categorized and just huddled up like sheep, and it's not the way to go to treat individual people. I think focus on one person, move on to the next. That's the way I would work personally. I know it'll take time to get into that way of working, but I think that's what I would prefer as a patient as well.
Yeah,
right. Just for me there, I often describe this as a hub and spoke model, where the individual is at the center, and everybody else works in spokes off that.
Mm-hmm. Yeah, I agree with you both. So the word in there, just to reassure people, it's not my wording. That's from the standard that's pre-published. And not to defend the standard, I suppose, but the person-centered is honed in on it in other standards within the best practice standards. But I take your point that a change of the word in there would really focus us on that standard to make sure that the person is central to that communication and that partnership. So Okay, thank you both. So Lee, your slides are up. So thank you very much, Lee, for joining us. And yeah, over to you. And I'll do my best to keep quiet now for the remainder. Thank you.
No, it's fine. Feel free to chip in. Yeah, the plan for the session, I'll just introduce myself again. I'm Lee Campbell. I'm a advanced practitioner physiotherapist. I work in North Wales Brain Injury Service in Colwyn Bay, but covering the whole of BCUHB, and I also work in neurophysiotherapy. So I sort of span across both services. So what I thought I'd do today, I have summarised standard 3, but I can move through that a little bit more quickly because Nick's done a little bit of that already, and then outline our sort of service structure. So I know that I really thought about it when presenting this, whether to kind of maybe focus in on a more local service where I feel in many ways we are meeting the standards better with some of the multidisciplinary work. But I thought as it's an all Wales project and we're looking at variation, inequality, inequities, I thought it might be useful to look at more of an overview, because I think the way that neurological services are structured in the health board do have quite an effect on how we meet all the standards, but maybe particularly this one. So I hope I've not gone off piece with that, but that's what I've presented today, and I guess it will be a point for discussion anyway. And the challenges, yeah, that service structure presents, and then ways we're working to try and meet this standard. And then I've put just a couple of case overviews. They're not really case studies, but just to kind of map how somebody might move through that structure for illustration. So I might just read them out because there were a couple of people that are traveling and may not be able to see screens, and the writing's not that big. So Nick did summarize this. So standard 3 is effective partnerships and good communication are essential to providing seamless rehabilitation in the right place for everyone. This ensures good outcomes for people throughout their rehabilitation, including when moving between services and settings. So there are, you probably had a look at the standard, but it does break it down in a little bit more into how that might look from the point of view of the practitioner and how that might look from the point of view of the person accessing the service. So from the practitioner's point of view, rehabilitation is organised in a way to ensure good communication and coordination between the person, the family, carers, and network to all agencies involved. And then there's some quality enablers. So from the practitioner's point of view, I work with and share relevant information with all stakeholders, including wider health and social care, voluntary and community sectors, and the third sector. I know who is responsible in the delivery of each of the person's rehabilitation goals. I can easily access specialist and expert advice and support as required. I know when and how to transfer care and can manage transitions between all community rehab services effectively. And I actively listen to the individual, their family and carers, and what they need. So that just lifted straight from the guidelines, but I thought it might just be useful to add that detail. And then from the perspective of the person accessing services, everyone involved in my rehabilitation is clear on what's happening, when and why. This includes me and my support network. So perhaps that, coming back to your point before, I suppose that does make it a little bit more central to the process. So when I'm seen, it's by the right person with the right skill, doing the right thing at the right time in the right place. Everyone I see has all the information from other services that they need, and I don't need to repeat myself. My support network and I are listened to and are involved in all aspects of developing and updating my rehabilitation. I know who's responsible for coordinating my rehabilitation, how to contact them. My family is made to feel welcomed in appointments and can choose how much they're involved in my rehabilitation. Yeah, I know it's a bit wordy reading that out, but there's a few people that weren't able to look at the screen, so I know it's a bit wordy. So there's also some supporting resource in the document, and they focus on, well, I'd provide a little bit more detail on multi-professional working, care involvement and support, sharing of information and communication. Although there's quite a focus on sensory differences, also need to consider the wider range of communication difficulties, including cognitive difficulties, Welsh language, and just preferred medium for communication. So although the background to the standards is very much about supporting people, as Nick's already said, with timely access to equal and equitable community rehab, no matter where they are in Wales. And as part of that, it does kind of focus on needs-led and not always needing to access condition-specific or specialist rehab. But I do think that people with neurological conditions do also need to access specialist neuro services integral to their rehab, often at multiple stages throughout their journey, which is why I have chosen to do what I've done today, although there is quite a focus on those specialist services. I think the way that people move between services and we work the services is quite key, and is not, that's always going to be something that people also need as part of their rehab. So what is the challenge of delivering a quality whole system integrated approach to neuro rehab within BCU? So I won't read out everything on this slide. I don't know how much people can see the detail, but I thought I'd just put up the kind of population estimates and the size differences between the health boards, because there is quite a lot of variation. So we're the largest health board in Wales, both in terms of population and size, covering 6 counties, and they are quite diverse. We've got quite sparse rural areas like Gwynedd, and then quite densely populated large towns of Wrexham, Flintshire. And then a couple of additional factors. We've got a large retirement population and also quite a kind of fluctuant population with holiday makers, and that also does sort of add pressure and make some changes to healthcare provision. So just to kind of set the context there. So in terms of our setups, we've got 3 large acute hospitals and 14 community hospitals. We've got 6 community rehab teams. But we depend on tertiary services for all our level 1 and level 2 rehab services. So they're, apart from stroke services, all neurospecialist services are external at level 1 and level 2. And that's through Walton for neurology, Stoke for major trauma, and then Robert Jones Agnes Hunt, also known as Gaboan, in Oswestry, and Southport for spinal and complex specialist orthopedic care for people with neurological conditions. So at the level 3, we have got non-neurospecialist community hospital provision, so people can have rehab in those, but it's not neurospecialist, and neither are the community rehab teams. We do have limited specialist neuro rehab services. So again, apart from stroke, we've got neurophysiotherapy and the North Wales Brain Injury Service, which is a multidisciplinary team, which is neuropsychology led, but it has occupational therapy, physiotherapy and speech therapy, as well as neuronavigators, which I'll come on to a little bit later. So I'm not going to go through the staffing levels. We are quite minimal, a very, very small team, but I will put it in the notes section if people want to look at it afterwards, or if you want to ask me about it afterwards, I can tell you about it. So just when we're thinking about sort of access and equality and access and variation, I thought it would just be useful to just give a little bit of the geography. So I don't know how clear this is on your screens, but so the most northerly drop pin I put on is Southport, and the most southerly there is the Robert Jones Agnes Hunt. So they are the places that people would go for spinal rehab, and if I understand it correctly, they would go to Robert Jones Agnes Hunt and Oswestry unless there wasn't a bed, in which case they would go to Southport. But we do see people accessing both, and they have their acute care there and their rehab, but then they also keep going back there for ongoing specialist care long term, if it's something that can't be met locally. And then there is Stoke over on the east side, the furthest east at drop pin, and that's a major trauma centre. And then there's a Walton Centre, the one drop pin in the middle, just above Liverpool, and that's where people go for neurology services and specialist neuro rehab. So just you know, I know that people live in different places and there's always going to be a variation on travel time, but I thought it's just useful to put out just how challenging that is for people. So, you know, people living north of Anglesey, Amlwch, to get to a spinal appointment or to visit somebody that's in a spinal unit would be 2 hours by car, 100 miles. But that's for people who have their own transport and can drive. Public transport is another significant difference and cost. And then hospital transport, where the ideal is it is provided, but over these longer distances, I think the reality is often these are the distances that sometimes there isn't the resources for, so they end up getting cancelled. There can be very, very long waits for people very far from home. And then also it's really difficult to get escorts and companions traveling. So people sometimes end up going to an appointment on their own in a completely different place, a really long way away. And, you know, I don't need to tell anyone with this audience that the needs that people have often make that really, really difficult for them. And I would say from talking to a lot of people to the point where it becomes impossible and they actually don't go to appointments and they don't use those services. So yeah, it poses a big challenge in terms of that kind of communication and partnership working, but also the access to specialist services. So the challenges for practitioners, I could kind of keep reaming them out, but really the basics. So even within our health board, and I'm sure that people find it within any system they work in, and we've mentioned it this morning with shared email address and stuff, even within our own health board, we're in different systems, different note systems, records. When you then take that across the number of different providers we're working with, it's really challenging. We're having to order notes in a timely way to make sure we get them back. We have to request things. We have to go through data requests to get them. So it's very time consuming and you're having to plan ahead quite a lot on what information you need when you need it. We can't look at things like scans from different systems. Again, that all needs requested because it's all external systems. The networking is really significant because it's quite hard to keep track of who's working where across that range of services. And then there's lots of transitioning between services. So when that kind of slide about seamless care and somebody always understanding where they're up to in the rehab process, it's absolutely at the heart of what we all want to do, but there is an inherently built-in challenge to that with just that number of contact points and different services. And then obviously the other challenge is just time, and I'm sure that everyone is the same, is like the administrative time is really minimal, and so clinicians are having to do quite a lot of that administration of finding all that information, and not only finding it but sending it back out so that you know, if the person that you're seeing is going to a specialist appointment, that you're getting the information that they need to them to understand where somebody might be at in terms of more local rehab. So the challenge from the person's point of view, yeah, the travel it's a really big burden for time for people that have got fatigue, people that you know, can be really uncomfortable sitting still for that long. It can be really anxiety inducing. Again, I think to this audience, I don't need to point out the challenges. So it really affects access, and then the cost, it can be really significant. So if the kind of unpredictability, and I guess the fact that transport is often not very needs led, with the service that we have, is people then quite often will have to choose to try and use like a car and have to pay for that, and that ramps up their costs. So there's quite a lot of cost implications. It's difficult, that same issues in terms of cost for family, friends, and that kind of network. So I've spoken to quite a lot of people that have been in a rehab unit far from home, and that lack of having your friends and family being able to drop in and be around you is really isolating. And I think also if people are, you know, going to be coming back to their home, back to their community, they've been isolated and disassociated from it quite a lot. So I think even in terms of people's loved ones, understanding where someone's up to in their rehab, that is also quite disconnected when someone's so far from home. So, you know, I've had some people that are only able to visit their loved one once a week, for example, and that's has a massive effect for both sides. So yeah, same challenges, different systems, different health boards. We would love to think that the communication's seamless, but I think that people do end up having to do quite a lot of picking up their own information, taking it between services a bit, and that multi-professional points of contact is not ideal. So yeah, I think I've probably covered all I need to say there. So we have tried to put things in place to try and meet this challenge and try and improve communication and partnership working. So we have got multidisciplinary services. So my alternative for today was to present something where I feel it is working quite well, but I haven't done that. But so North Wales Brain Injury Service is a multidisciplinary team where I feel that communication, because we are one group of professionals working together all the time, is we are better able to meet this standard. So I think once people are in those services, that's much easier rather than when they're moving between them. So we have those. We've got joint MDT clinics for certain conditions and multidisciplinary clinics. And they are open to people to come in. So it's we encourage people who are working with different clients to come in. That might be from health, social, anyone involved in the care can come in and discuss their multidisciplinary needs within that clinic or those clinics, and they're every month. We've got really strong links and working relationships between community teams, neurophysio and the brain injury unit. So we do quite a lot of in-reach and outreach work. So if people identify that they need some support, we can work between them quite flexibly. And then we've got things like disease-specific advisory groups or condition-specific, and they are supported by service users, range of clinicians, and they're trying to work towards kind of best practice, aligning services, aligning care, trying to improve services. So they meet regularly, and that improves communication and partnership working. And sometimes we do get people coming in from some of the external providers to improve those links as well and help us both understand what services we have and how they're working. We've got the neurotherapies clinical network group. So as I explained before, we've got quite minimal specialist therapists working in our health board, but the clinical network group means that people who have some contact with people with neurological conditions can come into that, and that can help the clinicians know where they can go to get support, but also it helps us kind of identify when there's areas that need improvement. It helps us try and make pathways better. So it's a group of therapists basically who try and promote best practice, including looking at aspects like these guidelines. I think, Linda, are you asking who runs the clinical network group for therapists?
I was just wondering if there was is there a consultant lead to that, or is it very much an allied health professional?
Allied health professional. So we actually decided to take it in turns to chair. So I guess it's led by the advanced practitioner physiotherapist, because that was the way we set it up. So myself and Hannah Willis lead it, but we have got a rotating chair so that everyone kind of takes ownership in that group and has that kind of shared responsibility. So that is how that run, and then the minutes are circulated. So so it is shared out with therapies. And one of the things that came out around that was that people felt they needed ongoing regular training, particularly when they're not working neurology all the time. So we set up like a grand round. So that's a monthly lunchtime half-hour training session on a range of topics. And then we do like drop-in sessions where people can bring cases where they need some support and discussion. And again, lots of clinicians find it quite hard to know what's happening in this health board, never mind what's happening in terms of external providers. So that's a way of us trying to kind of explain service to people and try and pull things together. There are some condition-specific specialist clinicians and care coordinators. So they are like in MND, Huntington's, MS, Parkinson's, neuromuscular conditions, and they've got quite a role around that kind of linking things together. But as far as I know, they don't have capacity to work as case managers really. So it is pulling things together, but it's not that sort of next step towards really trying to help with that seamless care. And then there's a new role, and I don't know very much about this, but there is a new neurological link nurse post. And I'll come back to that question in a sec. Neurological link nurse post, and that is between the hospice care and other services, so that that aspect of neurological rehab and care links in more. But it's a relatively new person. I don't know a huge amount more about it, but that is another thing. So these slides are different because I've literally pinched them off the Neuronavigators. So this issue of people moving out of area, coming back to area, sometimes having to go back out of special services was identified as being a problem, and the Neuronavigators came into post within the brain injury service last year, and their role was around trying to ensure neurorehab happened in the right place, the right service at the right time. Now, obviously, it doesn't overcome the fact that it's where it is. It's still geographically out there because that's the service we have. But they were set up to try and help with these transitions so that people had the right information. So say somebody was in a rehab unit, there would be that preemptive information that they're coming home, the communications would be in place, the information would be shared, so that will hopefully be a much better experience for people than prior to the neuronavigation. So I won't read out all the detail of this, but basically they help at every stage of the process. So it's probably really small, isn't it? But they can assess in that acute setting and help provide advice about where the person rehab needs may be met, and then manage the transitions at each stage of that, both with working with the person, their family, but also the clinicians involved, and coordinating all the stages through acute rehabilitation and then coming back into the community. They are also really good at identifying when it's not necessarily for people to move out of areas. So sometimes people's rehab needs can be met locally, and that's also part of their role, is identifying and I guess weighing up the clinical picture with the person's wishes as whether that is something they want to and can access. So that they only provide that service for people that have been referred to the brain injury unit. So that is limited to people with brain injuries. So I'll come back to 2 questions. So that is through a referral into Nubis, and then they assess and then go from there. The element that I didn't mention, just looking at this, is I didn't mention the funding request side. So when someone's rehab needs are identified, then the funding request needs to go through, and they also facilitate that. That can be an additional barrier really and has quite a lot of built-in delays while people are waiting for funding to come through. They may end up being kind of stuck on a ward or something. Do you want me to answer the few questions now? Would you mind reading them out, Nick, rather than if I move off slides?
Yep, sure. So we had a question from Jane. Is the clinical network restricted to the NHS workforce only? So I think that's the neuro condition network group.
The people that are on it regularly are from the NHS, but we invite people in depending on what the discussion point is. So we have kind of an agenda and different things that we're looking at, and then we kind of invite people in to talk or invite people in to be part of discussions depending on what the subject is, because sometimes it is really, we're looking at kind of quite a health board focus, and other times we're looking a little bit wider into more partnership work. So a variable basically.
Okay, thank you. And then Lucy Morris from Carden Vale Neuropsychology has said, out of interest, what clinical background or training would the neuronavigators have?
So I wasn't involved in the recruitment, but I can tell you what background the two that are in post have. So one is a neurospecialist occupational therapist, and the other one is she's nurse by background, but she's had quite a lot of experience working in different neuro rehab settings and kind of case management.
Thank you. I think they were all the questions.
I think Reese might have a raised hand as well.
Oh, Reese, sorry, I can't see that. Yeah, Reese, have you got a question?
Sorry, I wasn't sure if you could see my hand or not. Yeah, just a quick question. When patients are discharged from this scheme, when you've in the middle section, you had into rehabilitation, you had discharge from MDT. My biggest concern as someone with a neurological condition would be if I had needed to use the services again, how long would it take me to go back to that after? Would I have to go back from the start?
So I would say that it's different depending on what stage of the process. So I think what I have focused on quite a lot in this talk is services that are external to the health board. So within the health board, like the multidisciplinary team, like the brain injury service and neurophysio, people can self-refer back in. It's a local service. I feel and I hope we do that, meet that standard and do that seamless service and partnership much better. But I think where the challenge is where people are going out with the service, and that is a question of referrals going back in. So that can involve quite a lot of delays. So for example, if I was seeing someone, one of the cases I looked at later is seeing someone with MS, and a community therapy team were going out, they identified a need for more specialist assessment, and then maybe one of us neurophysios would go out and assess. Then if we identified, say, the need for Botox, we would then have to write a letter to the Walton Centre to request that specialist service. And then realistically, that could be like 12 to 18 months. So in terms of delivering that kind of rehab package, if that's really integral to that person's rehab and the next stage, that is a kind of a built-in delay that we don't have a huge amount of effect over. Does that answer the question?
Yeah, completely understand. Yeah, it's just with people with like either progressive or relapsing remitting MS or something like that, where it plays up and down, and they might be okay for a period of time, and then they might need to go back into something quite imminently. My concern was, that they wouldn't have the opportunity. There would be a massive delay, and it would affect their well-being.
So I would say the delays, from my perspective as a clinician working and from talking to people, delays in and out of some of the special services can be quite challenging. I would say within the health board, once someone's in local rehab services and we're not needing to access external care, I think that doesn't have many built-in delays at all. And one of the really positive things with I guess working in the health board is that you do tend to get to know people that are working in your locality. So it's self-refer, we're in regular contact, and I think that communication's pretty good. Obviously we need to ask people we're working with, but
okay, thank you.
So in terms of future developments, I'm just aware of time. So I just put up some other things, I guess maybe things that we might be able to do, things that we could do. So it might be that the neuronavigator role becomes more developed across other areas of neurology. I don't know, I'm not in a position to kind of make those decisions, but it does feel like that makes a big difference. I guess there's quite a lot of guidelines that talk about like a single point of access, or like a case manager, a key worker, and I guess that would potentially have the benefit of helping somebody navigate the system and be their kind of single point of access, and be the person that helps share information when that is more challenging. We've got quite a lot of kind of, I know I've probably focused more on communication and partnership, but we've tried to develop partnership in lots of different ways. So there's all Wales groups and there's collaborative ventures with Walton, which just mean that we get to know them better, we get to understand their services and vice versa. And then, we've got ongoing events with a range of parties and services, third sector. So I've mentioned a few of them on there. More networking like this, so we can understand, people can understand the way we're working, and then the links with universities as well. So we're running like an upper limb study day later this year with Bangor University, and that is across like stroke and neurology and things like that, just help to kind of bring services together and improve communication between us. So I already kind of mentioned that case overview, and I'm running out of time really, so I will move through that one. But just as an overview for somebody that, say, work with a brain injury, so they could have a situation where they're admitted to one of the hospitals locally. They might be transferred to Walton for acute management surgery. Then they might come back to a community hospital for discharge planning. I have had some people where, when they've come back at that point, the need for more specialist rehab has been identified, and then they've had to go back again after a funding request, and then wait for that admission, and then they come back to local services again. So, you can see again how much potential barrier to communication is built in there. And then throughout their journey, as I've already discussed, they would then need to come back in for neurospecialist services. Sorry for all my acronyms. I'm trying to not make the slides too busy. So just, I guess this summed it up really. We had a meeting last week, and one of our patients' wives talked about how things felt for her, and she was expressing what she would like to change. And so this is what she kind of said. One of the things she found most difficult was that she often felt like she had to go between different services. Services wouldn't really speak to each other. So she felt she had to make phone calls to try and chase referrals, inform services, which she just said was really exhausting when she had so much else to do and think about, and was really kind of challenging us to try and work out better ways of doing, of communicating. So I think it's a really, it's a really relevant standard. So hopefully what I've done is, I as I said, I'm not sure, it's a really broad topic, isn't it? And it's hard to know where to pitch it for a talk, but I haven't focused in on the minutiae of the services that I guess we're delivering more locally, but have really panned out to show how that service being delivered externally can really affect the meeting of this standard. So hopefully that was useful. And if you've got any other questions, I think Steve might still be in the background. It's the head of therapies, and feel free to ask me anything else.
Thank you, Lee. That was such an honest presentation, and really clear about the challenges that you're facing. And it's great to see what you're doing to try and mitigate some of those challenges. But obviously, I can appreciate there's only so much within your control. But it seems like you're working really hard to pursue every avenue you can to make sure you're able to deliver as best you can. You can see the applause coming in from the group as well. Wow. Okay. Thank you. That's brilliant. Really good. Before I ask any questions or have any comments, I'll open up to the group. There was a few hands that came up and some questions in the chat. I wonder if people would be prepared to put the hand up and ask the questions if they can. Or there is a hand up currently, and I think it's with Stuart first.
Thanks very much. A brilliant and very honest presentation, which I think is really what is most valuable to a group like this. I think one of the comments that I had was really about understanding the limited impact you feel you've got on affecting change. But for me, something that this group could really do is help with pushing that impact forward. So I'll speak on our chair's behalf, and he might shout at me, but what I'd like to see is you coming to us to say, we need help to do this. And so we can then be an external influencer.
Well, I mean, I feel like I probably should have put on the obvious really, but I think having worked in the healthcare system for a long time, I probably didn't put it on because I felt I couldn't influence it. But I think that shared IT, that would make such a huge difference to everything we do. It's a real barrier, that limited access, I so worked somewhere in Manchester where we had shared notes between like GPs and therapists, and that was just like honestly saved so much time. The care was so much better. That kind of sharing would be amazing, but I probably should have put it on there as something, but it's just something I feel like I've never been able to, I don't have much influence over. But that would be something I think would make a huge difference.
Nick, it's over to you.
Yeah. Thank you, Stuart. And yeah, no problem speaking on my behalf, because I know, Lee, we've spoken about this before when I met you in person in North Wales. The inability to share information between yourselves and those who are providing services to patients, albeit miles and miles away, is a big thing. I'm not entirely sure where we would start with that. I'm sure Steve has probably had some conversations around that as well. I can see his hand is up next. Steve, your point around that data, about the sharing of information, would it be suitable to come in on that, if that's okay with you, Ruth, and if you can come in after Steve?
No, my point wasn't on that necessarily, Nick. But I can comment on it. I think the challenges are that Wales like to develop their own systems, and they are not necessarily in line with some of the systems in England. That said, a lot of systems in England will be individually commissioned by each of those organisations, so they aren't necessarily compatible or shareable with each trust out there in England. So I think it's a really challenging one to solve. I don't know what the answer is. My point was more on similar kind of wider support, really, which I can come back in on after Ruth.
Okay, thank you, Steve. Ruth, do you want to come in on that point?
So the point I was raising in the chat is the project that's developing in the neurotherapy centre is beginning to look at the issue about waiting times that was brought up, and the impact of waiting times on people when they're accessing those other services, and what else can be done to actually support people whilst they're on that waiting list. So obviously could pass that information back. We've got a steering group rep, Rachel Sanderson, who's been really supportive, who's the innovations manager in the Walton Centre, and she's supporting us in those discussions. And I just wanted to add as well, in terms of the MS Society that I also work for, that there is that real focus on neuro rehab within the MS Society and the work we're doing, and it is neuro rehab. So I think, Lee, you mentioned the forum that's taking place as one of those partnership events on the 25th of September. And I want to assure people that we are not, MS is part of it, obviously, but it is looking at neuro rehab and really supporting that discussion, recognising that by bringing that in, all the conditions will, over time, improve the way in which their needs are being met. So, and there will be quite a bit of patient voice as part of that as well, and that in that forum, and we're supporting people to be in the breakout groups as well as speaking at the event. So I think that joint work that we can do as neurological charities, I think that's well, pointed out by Stuart, that is an important part of what the voluntary and community sector can do, is bring that voice of people who need those services and really generate an understanding of the impact. Because my experience of working with a lot of commissioners, and I know from the work that you're doing, Nick, that that knowledge will be developing in Wales, is that very often there's a lack of understanding of the impact of those services, and that does impact on the way in which services are then designed. So those were kind of the thoughts I had. But Lee, the presentation was really, really useful, because it just gives such a good overview of what is currently happening and, the guidance in relation to the services. So thanks for that.
Thank you, Ruth. Steve, your hand is still up. I think it's to come back in on the point you initially raised. Do you want to come in there?
Yeah, so I've been involved in neuro for several years now, in terms of it being within my portfolio in a kind of senior leadership role. And we were looking, and we have been looking as a health board, and the health board in its various guises previously as three trusts, to look at a level 2 facility, or the potential for that in North Wales. And we've done quite a lot of work in terms of scoping that. One of the difficulties has been, it's quite hard to try and find the actual cost of what it costs with each of the providers and any of the individual patient funding requests. We have attempted to do this, and our attempts have got us to the point of about 2.5 to 3 million that it's costing, and scoping what it would cost to actually develop a unit roughly initially was about 5 million. So the difficulty with that, and this is just, I'm just talking financial costs now, I'll come back obviously, and he's highlighted all the costs of the patients of having to travel to different facilities and out of North Wales, which I think has to be fundamentally put at the heart of what we provide rather than it just being the financial costs. But if you've already got a 2 million revenue gap, and this is the difficulty of commissioning something versus providing it, and that actually from a financial point of view, a 2 million gap is not something we would necessarily be able to get support with as a health board. That said, we've got a briefing paper that's going to be going to our execs, primarily to outline the challenges of where we're at in relation to level 2 and level 3 services, and all the things that Lee's talked through in how we repatriate people and get them back. And actually, could be argued that we're incurring additional costs by people staying in places that they shouldn't be for longer than they need to be. So that briefing paper is going to go to the execs to look at where we position neuro within the health board planning and going forward, really. That's not to say that we'll necessarily end up with a level 2 facility, but all the work needs to happen, and the scoping and the whole kind of business case around that. We got to a point with it where we thought, well, we need to map our level 3 services in a little bit more detail as well. And there are lots of neuro patients that are seen in our wider community rehab teams, as Lee's outlined, but they're not neuro specialists. They're just patients that happen to be part of their caseload and are presented with a particular reason for referral, shall we say. So I think there's a lot of more work for us to do. We've tried to improve the situation as much as we can with the resources that we've got, but it's fair to say we've still got a long way to go on that, and hopefully we'll get some executive support around that as well. So coming back to, I think it was Stuart's point around sometimes to influence these things, it's through multiple avenues really, and some of that is through applied pressure, if I can call it that, from partners or third sector or other organisations around asking the question, because that raises the profile of it then, and helps support our case really.
Yes, Stephen, thank you for that. As you were talking, it was making me think, well, how can we in performance improvement, how can we support that? And I wonder if maybe I could pick up with you in another meeting just to see if we can support that at all and add any weight to that. We're doing some work around level 2. We've had the seed up report, which Lee, you were involved in, and a few others around this moderate to complex patient group. So I wonder if I could maybe link in with you after this meeting. Would that be okay, Steve? And maybe yourself, Lee, and see how we can support that.
Yeah, and Craig as well. Craig, who
absolutely, yeah, Craig.
Yeah.
Fab, thank you. I'm conscious of time. We've got 2 more hands up. If that's okay, we'll take these questions and points, and then we'll move swiftly through to Esther to see what the work of Esther and Carden Vale, if that's okay. So Ram from Powys, you've got your hand up there, Ram.
Thanks for the excellent presentation, Lee. I think we echo similar thing in Powys. So I work as a consultant therapist for stroke and neuro, and we have similar challenges what you have on your geography, and also to repatriate some of those complex neurological patients back into Powys. And I quite like the idea of neuro navigators, which I think which is very helpful to communicate and coordinate the care. What my question is do we have similar challenges on workforce shortages and recruiting those to specialist positions, and also retaining those specialist positions, particularly if we look at neuropsychologists or highly qualified experienced clinicians and access to those? What challenges do you have on the workforce, and how you retain that, and how they provide the training? I think in Powys, we have similar challenges, which we are unable to recruit to high positions and retain them. But is it similar to you?
Steve, do you think, is that more of a question from you? I mean, from my point of view, like I think it just seems to be very challenging to get the funding through to even go out for recruitment for these posts, as far as I see it. But Steve's probably got maybe a bit more an overview of that.
Yeah, we managed to get some funding, but it's without going into any detail. I think the ongoing element of that is a little bit sketchy, but we did manage to get some funding based on the benefits of putting these roles in place and repatriating people earlier. We'd be happy probably to share kind of details around job descriptions or anything like that if you were interested. I was on the interview panel for those community navigators with Craig and one of the psychologists, so happy to link in with you outside the meeting about that if you want to get in touch.
Yeah, it'd be very useful, Steve, because we have this complex. We want to repatriate early and bring that funding back into the community, but at the same time, development of those roles would be crucial for that. Thank you.
Thank you, Ram. Thank you, Steve, for jumping in on that. I think last hand up then before we move on, Reese, if you'd like to come in there, please.
Yeah, thanks. Yeah, I was basically what Jenny's just said in the chat. That's why I have my hand up for 10 minutes. What I do as a patient is I do subject access requests, get all my notes, collate them, and put them into a simple overview of my most recent care and update it when I have an appointment with a consultant and take it to my next appointment. I find it's just a nice summary to take. You don't have to explain everything, and they can see what you're doing, and also keep a record of my medications and stuff like that. It's what where I have care in London and the University College London hospitals. They got a system called My Care, and that's basically what it is a summary of everything. And it's really useful. But the problem is, because they said before, someone said none of the health boards, NHS trusts communicate. So I'm going as an in-between, putting it all together, updating it, and taking my own notes. The problem I've spoken with Digital Healthcare Wales about getting the systems updated, because they've got the new system where you can apply for records from your GP via the NHS Wales app. But the problem with that is you can't access, you can only have limited access to things, so you can't have specific things that you need. And it's very GP surgery specific as well, which is another problem I've encountered, because I've applied to have my advanced notes so I can access certain things. But again, with that, because there's, I know they've got now where the NHS, for example, can share like, radiology reports, and they can view scans from each other's health board area, but patients don't have that facility with the app, so they're unable to do that. And it just causes more barriers, and I think it needs to stem from NHS, Digital NHS Wales, or whatever they're called, Digital Healthcare Wales. So is there any chance of having someone from Digital Healthcare Wales involved in these meetings?
Yeah, we could certainly make an invite to them. I've got a request to the group actually. So DHCW are trying to, so there's some AHP, so allied health professionals within DHCW are trying to scope what software and operating systems AHPs are using in their services. So that would cover us. So there's a question there it's on some slides later, asking if AHP leads within these different teams are on us group, where they could be in contact with DHCW and just explain to them about the pinch points and the difficulties they have with the interoperability of the different services they use. So it's a really timely comment, Reese, because that's exactly what their request is about, is trying to find out what works well, what doesn't, and why. So the issues that Lee has mentioned, I hope will come forward there, and their role is then to try and support their interoperability and to try and support that. So I can put the invite to that person. So his name's Stephanie, and I can certainly ask them to come along and see if they can pick up on some of these issues.
I'm sure they get a lot of questions.
Oh, they do. I think they get a lot of questions, around data and the systems. I'll be right. There's comments in there about patient-held records and digital interoperability, really difficult space. And Michelle's already put it in there, it's under development, the NHS Wales app. So there are ways forward. I think it's just slow, and we haven't got the clarity right now. Okay, now I know there's lots of thumbs up and maybe a couple of questions we missed in the chat, but if people are okay for time, we're going to move through to Esther. So thank you, Lee, for that really honest presentation. Any questions people have got following, send them through to us, and we will forward that on to Lee, and we can try and get those answered. So Esther, I think, have you got a presentation to put up, or are we putting that up on your behalf?
I've got one, so hopefully. Yeah.
Great.
Can you see that now?
Yes, we can see that. Thank you.
Lovely. So I'm not going to be able to see the chat, so please do stop me if you've got any questions. So yeah, good morning, everyone. My name's Esther. I'm the speech and language therapist in the Live Well Community Neuro Service in Cardiff and Vale. And I'm really grateful for the opportunity to share with you our partnership model. First, I'll just give you a quick overview of today's presentation. It's going to be quite different from Lee's. We're hoping that it will complement each other. So I'm going to focus in very much on a specific model of service delivery that we've got running in Cardiff and Vale. So I'll introduce the model, just explain a bit about what it is and who we are, and how it links to the Standard 3 communication and partnership, how we support and enable patients living within Cardiff and Vale with neurological conditions, the aims of our clinical model and our service delivery, so share with you some of our outcomes and how we link to the strategic objectives for the Health Board, and then finish with some reflections and our future plans. So it's rather a wordy title. So Creative Communicators is a group-based collaboration between the Speech and Language Therapy Services of the Cardiff and Vale Live Well Neuro Community Service and Cardiff Metropolitan University, and also Chroma Therapies, which are a private arts therapy organisation. And as part of this collaboration, we run community-based Live Well Neuro communication groups jointly at Cardiff Met. To our knowledge, we're really excited that this is the first collaboration of its kind in Wales, and we're very grateful to the support from the Bevan Commission. So I'm one of the Bevan Fellows for 2024 to 2026. And to explain a bit more, our Live Well Neuro Service is a large multidisciplinary team working in partnership with local services to provide co-produced, group-based living well interventions, both online and within community settings for people with neurological conditions in Cardiff and Vale. And our model specifically supports the Welsh Government Health and Care Quality Standards and the National Clinical Guideline for Stroke, the UK and Ireland. So some dubious photos here. So that's me, Esther. I'm the speech therapist in Live Well Neuro, and I'm joined there by Katie Earing, who's one of the senior lecturers and SLTs at Cardiff Met, Anna Kizik, one of the other senior lecturers and speech therapists at Cardiff Met, and then our wonderful music therapist, Vicky Guys from Chroma. And when I joined this service, which was originally our community neuro rehab service, I was working with Katie on a research project at Cardiff Met, and we got chatting about the exciting prospect of trying to set up groups for individuals with communication difficulties and really how and where to run them. So Katie was explaining to me about the new clinic area they got set up at the university, and we got talking about how a possible collaboration might work and be beneficial to all. So I was only initially 1 day a week in the service, and it was just me from speech and language therapy. So I had a bit of a blank canvas. These groups hadn't been running for a while. So, you know, it was a real opportunity to think outside the box about how we could deliver these services. So our model links directly to Standard 3 communication and partnership. I'm not going to talk too much about this because I think we've heard quite a lot from Nick and from Lee this morning. But there are many benefits to our partnership model, which hopefully I'll explain in more detail as we go on. Importantly, we aim to demonstrate the principles of right place, right time, right way. And our project delivers high value personalised care with patient goals and quality of life at its heart. And we hope that it represents a forward-thinking cross-boundary co-production between the NHS, education and the private sector, but importantly and crucially, always keeping patients and their voices firmly at the centre. So how do we support and enable people? What's our plan? So as I say, this is purely speech and language therapy focused. We run community-based Live Well Neuro communication groups, and we want to really continue the development of this new value-based collaboration, which aims to be sustainable, empowering, effective and efficient. And we do that by sharing resources across health and education, meaning that patients can access this much needed community-based service, but hopefully with additional benefits to themselves, the NHS Live Well Neuro and Cardiff Met. And we want to enable individuals with Cardiff and Vale with communication impairments resulting from long-term neurological conditions to live meaningful and fulfilling lives, and importantly and crucially for them to provide a community. And we think this innovative service model is very special for a number of reasons, really. As I mentioned, we're able to offer more groups than a standalone NHS service. So originally it was just me in one day a week, and we're now able to run with this model up to 3 groups in one day. And by efficient and effective use of shared skills, expertise and resources across the sectors, we are optimising patient waiting lists, increasing capacity and improving patient flow. And the academic partnership provides patients with a strong community base. So we're doing, real world focused functional therapy in a community setting, but alongside direct clinical and student support, research opportunities and access to the latest evidence-based practice. And patients and their families and carers are actively involved in our evaluation process. And this serves as both a clinical outcome measure, but also as a valuable method for gathering feedback to inform the design of future groups. We really want patients to be involved in designing the groups that we run. So for the last cohort, we've just finished running a conversation group, a writing group, a Parkinson's communication strategies based group, and our wonderful Cardiff and Vale aphasia friendly choir, which is very much the cornerstone of our project. And I just want to say that we're really grateful to receive funding from the Tavistock Trust for Aphasia for our choir. So the aims of the clinical model sort of fall into 3 broader categories: leadership, research and teaching. Leadership, we want to share this vision with health and education colleagues across all therapy disciplines, both within the UHB and further afield. Research-wise, it's a really perfect opportunity to complete some valuable cross-boundary clinical research. So evaluating the groups and scoping future provision enables the patient voice to be heard and future services to be co-produced with patients and the public. And another key element of this model is the provision of clinical placements for student speech and language therapists. And the groups can provide a really broad hands-on learning experience for the students. So immersing them in the groups at the very beginning enables them to have a degree of independence that's perhaps difficult to achieve in other clinical settings. Being based at the university and with a clear emphasis on student involvement, this collaboration is a simple way for us at the Cardiff and Vale Adult Speech and Language Therapy Department to offer really valuable clinical placements, something that just can be really challenging due to clinical pressures. I see it as very much a reciprocal relationship with the students. They bring new ideas, resources and support. And it helps prepare students for the future workforce by developing their understanding of collaborative value-based working that promotes self-management and a preventative approach, hopefully shaping the direction for future collaborative initiatives. And we also have music therapy students that join us for the aphasia friendly choir on a volunteer placement setting. And this enables us to raise awareness of communication difficulties further across other disciplines, and also provides our speech therapy students with interprofessional education hours, which again can be challenging to get completed as part of their professional registration. So how it works in reality, the NHS-based Live Well Neuro retains the duty of care, manages referrals and the clinical and administrative aspects of the service. Cardiff Met provide a fantastic clinic space which is fully accessible, and they've also got cafes and everything on site and a waiting room, support from student SLTs, research opportunities and up-to-date evidence-based practice, and then direct clinical support running the groups. So we all run groups individually and together as well. Model, as I said, is based on these 3 principles, and I'd just like to share some of the general outcomes across all 3 areas. So under leadership, we had a successful funding application made to the Tavistock Trust for Aphasia. And this has enabled us to have 24 sessions of the choir from 2024 to 2025. So with the choir specifically, my time is obviously comes through the NHS, Cardiff Met's time comes through Cardiff Met, but we source external funding for our music therapist for 2 hours a week to run the choir. And thanks to the provision of a larger room from Cardiff Met, we've been able to offer the choir as a rolling group. What I mean by that is that it can be open to previous, current and new patients for the duration of this period of funding. So I think we found that people were coming together, and by the end of the 8-week block, so we run in 8-week blocks, they were really gaining confidence with their singing, but more importantly, building a real sort of social network and a sense of belonging. And they wanted to keep going. So we're delighted that we've been able to find a way to support this. We're also spreading and scaling the model across other SLT services within the adult service at Cardiff and Vale. So they're hoping to adopt the model and also discussions to adopt it across other therapy disciplines within Cardiff and Vale, and also nationally with some of our partners in North Wales speech and language therapy services. The choir was invited to sing at the Royal College of Speech and Language Therapists' 80th birthday event at the Senedd earlier this year. This was a wonderful opportunity to showcase the work of the choir and the dedication of the participants involved. And we got the Health and Social Cares Minister doing a breathing and vocal warm-up, so everybody got involved. And we are also going to be singing at the Cardiff Met Christmas Carol service in Llandaff Cathedral later on in this year. And the spread and scale, again, is supported by the Bevan Commission. So I recently presented this model to the chair of the Bevan Commissioners, and it was very well received. She was particularly interested, I think, in the student involvement and the music involvement in rehabilitation. So looking at some of our research outcomes, we've had several posters that we've created based on the outcomes of the collaboration, and they've been presented at various conferences over the year. We presented at the Well Stroke Conference this year, and we're due to present at the British Aphasiology Society International Conference in August. And we had a publication in the International Journal of Language and Communication Disorders, and this was actually based on our inpatient aphasia-friendly choir, which is directly related to the community choir. So our community choir grew from the inpatient choir. And as I've mentioned, the teaching aspect is really crucial for this partnership. So we have 10 direct student placements with the communication groups over the last year, with students developing increasing levels of independence and facilitation of groups. 18 students have had direct contact with the aphasia-friendly choir, with additional students being able to observe and again feeding into those interprofessional education and hours. And I think what was really exciting for us was getting students involved in research and contributing to our much needed evidence base throughout their placement. So the 2 students that you can see here, they attended one of our therapies directorate research and development days. So alongside running the groups, they wrote an abstract, and it was accepted by the Well Stroke Conference. So they put together a poster, and it was a lovely opportunity to introduce them to collaborative research and working at an undergraduate level. And they presented it themselves on the poster tour during the recent conference. So really important, as we said, is our patient voice. We use patient-reported experience measures, which allows us to evaluate the groups, scope future provision, and enabling the patient voice to be heard and, really get them involved in designing the groups. This includes designing resources. So we've had quite a lot of feedback from participants with our resources, and they've got involved with producing those. And more recently, writing a song. So the members of our current choir, they've written lyrics about what it's like to live with a communication difficulty and what they want to share with others in the community, what they want them to know about what they experience. And our music therapist happens to be partnered with a songwriter, so he's written the music for it. And we've been working on that throughout the last block, and we're going to be performing that in Llandaff Cathedral at the end of the year. We're hoping for a Christmas #1, so watch this space. But obviously you can see here some of the comments that we've had from some of the groups. And in fact, I've just been going over some of the outcomes from the most recent groups. And I think one of the main things is the sense of belonging and also ownership they feel that they've got of the groups and the choir specifically. So how are we helping to deliver the UHB strategic objectives? So providing outstanding quality, we hope that this model benefits more patients and supporting them to live well in the community. Delivering in the right places, the community setting, as I've mentioned, allows for a real-world focus to functional therapy and acting for the future. So again, as discussed, an exciting opportunity to complete some valuable cross-boundary clinical research. And as I said, vitally, the involvement of students. So the project offers a sustainable workforce plan, developing skilled professionals, hopefully prepared to meet future healthcare needs and the needs of patients. So some of our reflections and future plans. I think our principal challenge continues to be around funding and sustainability of the choir and the other groups moving forward. The objectives of this particular project have been stable throughout, and I think this experience has enabled us to build research and leadership more explicitly into the clinical role. I think something that we found challenging all the way through has been getting really effective outcome measures. I think it's difficult for us to capture the benefit of the peer support, shared experience and the friendship that these groups offer. And I think that, often the first 10 minutes of each group is the participants coming together, sharing their experience for the week, anything that's happened to them. But they tell us that really that is the most important thing for them. And then future activity, I'm really keen to try and do a professional doctorate. So exploring the experience and opinions of the choir members themselves. Crucially, the sustainability of the group. So we want to develop closer pathways and relationships with some of the wonderful third sector organisations in the community. Further contribute to the evidence base for health and the arts, music and singing, and also obviously communication therapy more broadly, and explore mechanisms to share this project more widely. I think this is the first collaboration of its kind in Wales, and there is real kind of passion and determination to share this vision across Wales and the UK. This model and the community choir itself, we feel, is really replicable. I can never say that word, replicable across other health boards. And I think it's really important that we continue to gather data and share these at various platforms, such as these groups across Wales, to build and develop our evidence plan and support business plans for further investment in these invaluable holistic therapeutic interventions. And interestingly, listening to some of Lee's talk and the questions after Lee's presentation as well, shared IT is something that has been really tricky for us across education and the NHS. And third sector, and making sure that patients have a means of coming back into our service at any point. So as I said, we're an MDT. We're not open to self referrals, although that's something we're exploring, but we're quite careful to make sure that people have a mechanism to come back into the groups at a time that's right for them. So really, sort of hopefully building on this needs-led provision. Before I finish, I just wanted to leave you with a video of the choir, and I really hope that this works. The choir is one of our most accessible groups. I think given the structure and the aphasia-friendly resources that we have, which you'll be able to see in the video. And what I mean by those is we have PowerPoint slides that we project onto a big screen. They have all the words of the songs on them, but the keywords are highlighted. And there's also picture support there. The picture crucially relates to the meaning of the line as a whole, and this supports people with written language difficulties from their aphasia. Individuals can attend and participate, and more importantly, achieve, even with more significant communication and cognitive difficulties. Many of our participants tell us that singing is easier for them than speaking. And when they come together to do this collaboratively, it builds a really special community. It's something that is really close to my heart. I feel it's a real honour to be part of, and I wish it could be available to people across Wales and the UK more readily. So I hope this works. Please tell me if you can't hear it, and ignore the very dodgy piano playing at the end. So there's some references there if you're interested, and please do feel free to contact me for further information. My email address is there, and I'm very happy to take any questions.
Oh, thank you, Esther. That was fantastic. There's some hands up already, but what a great initiative. And it links really heavily with the previous standard that we looked at around utilising existing resources and strengthening existing resources, and then trying to develop those places and spaces. So it's a really, really good piece of work, Esther. You must be really, really proud. Reece, your hand went straight up. Do you want to come in?
That's absolutely fantastic. And I found as a patient, with neurological conditions, I found the biggest thing for me, for both my mental and physical health, is going out into a community group. For me, it's through cycling. I joined the board now of Pedal Power in Cardiff, and
brilliant.
we've started a recumbent ride on every Friday, with mainly people with neurological conditions. Most people have had strokes, MS, that sort of thing, and it's we're such a range of ages, but it's great to get everyone together, go for a cycle around the bay. It's physical, it's mental health as well. We can go back to the cafe then and have a coffee, have a chat. It's just for me personally as well, it's been the best thing I've done, I think, in terms of rehab, and that's why they asked me to join the board, to sort of use my lived experience and to help move it forward. And I think getting people with neurological conditions to attend anything of that sort is really good for them, and I massively endorse what you're doing. Well done.
Oh, that's lovely to hear. Thanks, Reece. I mean, yeah, I completely agree. I just think the value of these groups, bringing people together, that shared experience, you're the experts in your situation, and just giving you an opportunity to come together and build those networks.
Yeah, that's why I got involved, because I know I can sort of talk for myself and other people can't. So I want to put my voice out there just to get more people and to people be aware of these services. I think that's the thing, people aren't aware of them. And I think it was only by chance of doing when I did a para triathlon a few years ago with the Morello Clinic, the physiotherapy clinic in Newport, the neurophysiotherapy clinic, and they hired some bikes and trikes and things from Pedal Power, and that's how I found about it. I don't think I would have found about it otherwise, and I think people need to be made aware of these services, that they exist, and then obviously if people are using them, governments will look to add more funds to them to endorse them. And I think it's just about the communication element of just linking everything together from my perspective.
Yeah, absolutely. And I think I see, these groups have a responsibility to share some of these other organisations that are out there. We try and bring resources together so we can share them with people that attend the group, so they've got opportunities within the community as well.
Thank you.
Thanks very much.
Esther, I just had a query, if that's okay. Just wondering how it supports and what the involvement is from a person's network. So when they come to the group, thinking about the standard, how does it support their network, or is there an opportunity for their network to support their carer, the person brings them? Are they involved in the process at all? And then also, when the end of the block, when the block of sort of sessions comes to an end, that you said that they can come back in, but is there any contingency about how that group may then want to stay together or continue with the activity? What's the sort of follow on for them to, is there an ability for them to carry that on independently outside of the group? Or if, I don't know if you're able to comment on those.
No, I think that's something that we're really exploring at the moment. So in terms of people that bring them, and the support network around the individual, carers come to the groups and they often come together on site. We're looking to set up a carers group in September, because I think, again, they're so heavily involved, particularly for people with communication difficulties, because they're often their voice. So they tend to come and bring people. They don't come into the room because we want people to build their own networks and to support their communication needs to do that. But with their consent, we share everything and the resources that we develop within the groups with carers and their families. And we found that the families often go off to the cafe together. So they're building their own network, which is really lovely. And then we found that network then goes with them to some of the third sector organisations. So I know we've got a group that have been together and have come back into us. They've then gone to one of the Stroke Association groups, and they've to the carers group and the participants group, and they've ended up sort of building their network and keeping it going. And I think that's what, when we've been looking at sustainability, it's exploring those opportunities more, because I don't want people to feel that at the end of that 6 weeks they're falling off a cliff. So we're quite careful to, as I was saying, Therese, kind of build those networks with the third sector organisations. So we've got lots of things that we can, suggest that might be, they might benefit from, or they might be really interested in. And of course, we've got, we're a wide sort of MDT. There's lots of different types of groups going on within the Live Well Neuro service. So, some physical groups, but also there's a gardening group with OT. We've got managing uncertainty, some more psychology focused groups. We're about to start a peer support group. So it's making sure that people can move within the service flexibly, and then linking up with their referrers as well. Mm-hmm. So everybody is aware. And I think just because where we come kind of in the pathway, it's a real opportunity. It takes time. It really does take time. And I think triaging is something that takes a lot of time, because we want to really get to know and listen to the patients and find out where they are in their journey, and make sure that they've got roots back in, and just lots to be able to do. So, yeah.
Yeah, thank you. Yeah, that's great. And I just, unless anyone else has got a question, I've got another one to both Lee and Esther. But Lee, I think I'm going to pick this question up with you, Steve, and Craig in a later discussion. But Esther, is there anything that we can do within the network to support you linking with third sectors, which is one of the things I think you mentioned, and then also to support the spread and scale? So if there are interested parties on the call, is there something that we could do as a network to support that connection?
Yeah, that would be great. I think we've got growing relationships with the third sector organisations. Interestingly, today, well, in fact, earlier this week, we had 2 people who were attending the community third sector organisations groups wanting to come back into our services. So we're just exploring a mechanism for that, because we're not open to self-referral. But yes, I mean, maybe I could catch up with you another time, but developing relationships across all third sector organisations, and just making sure that we know what's going on more broadly within Cardiff and Vale is really important. And also across where people live on the boundary as well, and where people live on borders, make sure that we also know what's happening third sector wise within our neighbouring health boards. So, people might find that it's easier to go somewhere else. Mm-hmm. So that would be really helpful. And in terms of developing this model, I think it's just one of the ones that we found, it's a very small part of our overall offers, but it's a model that seems to work really well. I think just the sharing of resources, we're able to offer much more than we could if we were a standalone NHS service. We've got, obviously, because it was set up purely for this project, we've got all the standard operating procedures, everything's kind of in place. So we're really keen to share it. For other people who might have, if you've got a university discipline course and clinic space available within a city that's also, got a big community neuro offer, then bringing those together just seems to make a lot of sense for lots of people. And crucially for me, I think getting students involved in collaborative working and thinking about community rehabilitation and community support right at the start of someone's journey. And I think if we can build the future workforce to have that kind of awareness, so they start and hit the profession being aware that when somebody comes in, or when somebody's accessing more acute services, we're already thinking about how can we support them long term in the community.
That's great, Esther. And as you're talking, people are putting in the chat about their local choirs and how maybe they might be sort of talking, really making me think about what links there might be already. And I know that the Welsh National Opera have run programmes as well around sort of persistent pain, to support people with persistent pain. So I wonder if there's anyone if people are interested, if anyone working in services are interested to make these links and maybe have further conversations about how we go about doing this, then can you maybe get in touch with myself and the team, and then we'll try and set up a discussion perhaps between Esther and those to work out how best to take that forward, if that seems suitable. Okay, brilliant. If there's no more questions for Esther, then what I'll do is I'll just go back to the presentation I had at the beginning. Does that seem okay for everyone? Thank you, Esther. Okay, great. We'll round the session off. I know we're getting close to the end, so I'm just going to click through. We've had there we are. Right, so yeah, thank you to both speakers. Really good conversation. I've taken down some actions, but before we get into the actions, I just thought we'd go to any other business, just so we can, if anyone's got any thoughts or anything. So the next meeting is the 5th of September, and that is around effective data capture to drive improvement. That's the standard, and we've got talks from Linda, I believe, and Powys, I believe, yeah, from Owen Hughes, the Live Well service lead in Powys. The other thing on my list here is the DHCW, which links to the digital issues that we've discussed in this group already. So it's a really nice segue. So I've got a survey, it's about 6 or 7 questions. I wonder if I could share that with the entire group, and those who are using software and systems for patient notes and communication. If I could share that with you, and if as many people to fill that in as possible, will be really helpful to try and capture some of the issues that people have experienced in terms of the interoperability and some of the pinch points that they have with those systems. Did anyone else have any other business? No, okay. Actions then. So the actions, some we've already mentioned, is the evaluation form, which is in the chat, and also there's a link there, and we will circulate it again. It is really useful for us, particularly the I should and I will sections of those. If we can capture some of those, that might help us to form these themes that are happening and some of the actions as well. And we can try and put that back to yourselves on the whiteboard to support the implementation of the ones that we can make headway with. Some of the other ones I've written down as we've gone. So the terms of reference vote will ensure that we've had enough responses from the group to sign off the terms of reference. And if we haven't, and there's some comments, then we'll come back to you about those comments, and we'll make those tweaks and report that back at the next session. But hopefully you've had enough time to read it and everyone's happy with it. The issue around the co-chair, I think we'll continue to be honest and transparent around that process, and if we get any updates, we'll relay those back to yourselves as a group and work out how we go forward. So I know that we might not get the co-chair with lived experience in post for this iteration of the community of practice, but hopefully by the time we come towards the end of this, we'll have a clear idea and we can set it up ready for the next iteration come the new year. Other points I've taken down, so in terms of the whiteboard link, make sure the link is working, and then also to explore third sector and how we can get third sector involved in that as well. So whether it's a Teams channel or a PDF, I saw that Michelle Price had put into the chat, and someone else had mentioned EduMaps. So stuff for us to look at and to explore to see how we can support the group. I'm going to try and link with Steve, Lee and Craig just to discuss the level 2 work and see if there's any way we can support that, because there was a comment around sort of building that case and whether we can support some of that with the work that we're doing in the CEDAR report, which will be coming out soon, and we can share that with the group as well. Then there was a link between Ram and Steve regarding workforce. So we're linking colleagues from Powys and Betsy. We'll set that introduction up and we can facilitate if need be, or we can step out to whatever's required, but we'll put that in the email. The DHCW, to try and invite a colleague from DHCW to come to this forum to maybe hear some of these issues that we've got, and whether that's an ongoing attendance or whether they feel they need to come just for a session, we can try and plan that, and we'll liaise with them, but also I'll circulate that survey that I mentioned previously. And then Esther, I'll try and link with yourself then to talk about how we can best support you to link with third sector. We've obviously got, I think Shelley was on the call from WNA, and Anna. We're going to meet with them soon to discuss some work so we can see how best we can support you, and then how we disseminate that through all the third sector work as well. I've also taken down some themes as well, just to relay these back to you, unless there's any other actions people feel we've missed. So no more actions. If anything comes up, please send them through. We'll keep a log of them. But some of the themes have come up around the importance of follow-up discharge and re-referring. That's come through in some of the sections around how do people re-access services so they're not then waiting. There was a comment from Rhiannon, which we haven't come back to, Rhiannon, I'm afraid, which is around pathways and access to services. Access to service is specifically going to come up later in the sessions, and we've got the author of the paper around exploring access for those with MS coming to talk to us at that session. But I think your question was around service specifications, and after that discussion, which, thank you, which loosely, essentially, in my head, there should be one point of access. So it shouldn't matter what your condition is and what the pathway is. It should be one referral process, and that gets triaged effectively. So there's no handoffs. I think Hugh uses the phrase "no wrong door," so people go in through that one door and have their needs met. So that for me is how things should look. And if it truly go into needs based, then it shouldn't really matter what pathway you're coming on, because there's one access point and your needs are met. And although there might be some internal workings within that service, and you might move through that system, for the person it should be seamless. So this is part of the work around service specifications and seamless access, and some of the work that Michelle's looking at as well. So the follow-up and re-referral, there's delays in access, which we discussed, which is one of the themes. Shared IT and digital, which is a common theme, so that would already need to be built into these services. And then there was a comment around patient records, so patient holding the record. And Rishi mentioned about how you collate a lot of that work. You do a lot of that work to collate your records and support the teams, which is a lot of work for you, and it's good that you're able to do it. But we probably need to have some sort of something built in that we can manage that and as in services. So they're the themes I've taken out, and I'll add them to the document that I've been putting together. And if there's anything else that comes through from the chat and or any of the evaluation forms, then we'll plug that into it as well. Other than that, I've got nothing more to say. Just to say thank you to everyone for again, another great session, really good conversation, the honesty from yourself, Lee, about the challenge you're facing, but then really good to see that you're taking on as much as you can in terms of within your influence with some of the issues you've still got. But so yeah, really good work, some good conversation there. And then also Esther, the work that you're doing in Cardiff and Vale and with the Bevin Fellow, really good work as well. And however we can support them, please let's make that work. So we'll get in touch and we'll do what we can there. Unless there's any final comments from anyone, I can give you 1 minute back and just to say thank you very much, and we'll see you in September. Rihanna, for the. Rihanna, do you want to come in on? Do you want to make that point, or is that something you want to pick up after? I'm entirely up to you.
Yeah, no, it was only to say that it's great when you have a clear pathway of care into referral services and connecting primary primary and secondary tertiary care. But a lot of people with rare diseases, a lot of them that will have neurological symptoms but be part of a multi-system, get lost in the system because they haven't got those specialist services, so then lack the ability to get referred into these really important services that we've been talking about. So it's just about being aware of that. I know that it's not the purpose of this group to fix that issue as such, but it's just having that in your mindset when you're talking about existing ways of getting this sort of accessible service.
Yeah, really good point. And that's definitely something we'll talk about more in the access to services standard, because there's a specific piece of work that around supporting GPs to support people to access services quicker, and whether we've got a role to support them. Okay, that's lovely. Reece, you had your hand up, it's come down. Are you happy there? I thought you had your hand up there.
Sorry, was that me you were talking to?
Yes, I thought your hand popped up.
Sorry, I meant to click the thumbs up, what Rihanna was saying, because I got lost in the system and going between different health boards. That the delays is astronomical sometimes.
Yeah.
Sorry, when you called my name, you called me Rishi. I didn't think you were talking about Rishi, but I can't see him on here. But
oh, sorry. Okay, lovely. Maybe that's a point we can pick up in the access standard. But thank you very much, everyone, for your engagement today and the ongoing support for this group. I think it's doing really good things. It's getting people talking about really important issues, and we can try and bring this together. So thank you very much, and I hope you have a lovely rest of the day and week. I'll see you soon.
Thanks very much, Nick.
Thank you.